Welcome. Now I start the rest of my lecture on PDPH. Conservative treatment, IV and or oral hydration. While widely prescribed for treatment of PDPH, there is no evidence supporting the benefit of hydration for PDPH. Caffeine. The effectiveness of caffeine has been debated, but studies have shown a modest benefit to oral and IV caffeine. Caffeine is a central nervous system stimulant with side effects of insomnia, arrhythmia, and seizures, and should not be used for long-term therapy. Now, supine position. Maintaining the supine position after dural puncture is not effective in preventing or treating the PDPH. Other treatments, the most consistently effective and well-studied treatment for PDPH is an epidural blood patch. Natural course of PDPH. In most patients, the headache resolves after 1 or 2 weeks. However, performance of daily activities impaired in many patients and can last up to 1 month. Rarely, symptoms can last much longer. The importance of this is in parturients cannot be emphasized enough, as this patient population expects to care for an infant and often other children. Epidural blood patch. Effectiveness. The reported success rate of epidural blood patch varies significantly. In one study, the success rate of epidural patch in a heterogeneous population study that included parturients was 75%. The rate of success depends on the type of needle used for dural puncture, with large bore needles resulting in lower success rates. While the epidural blood patch is delayed for 24 hours after the dural puncture, it is more effective. Informed consent. The patient should be counseled about the possibility of repeat dural puncture and worsening headache. The most common complaint after a epidural blood patch is back pain lasting up to 1 week. Otherwise, the risks are equivalent to the risk of epidural placement. Performing the EBP, that is epidural blood patch. Meticulous sterile technique must be maintained. Many patients are not comfortable in the upright position, so the lateral position may be used. However, especially in patients with potentially difficult EBP, the upright position can be used, with care taken to minimize the time the patient spends in this position. The epidural space is localized. Blood is obtained under sterile condition by an assistant and passed to the person performing the epidural. After aspiration for blood and CSF, the blood should be injected in 5 ml increments to a total of 20 ml or until the patient experiences pressure in his or her head or back. The patient should often lie flat for approximately 1 hour, after which he or she can be reassessed for the resolution of headache. In the days following the procedure, the patient should be advised against heavy lifting and Valsalva maneuver, which may dislodge the clot. Patient follow-up is extremely important in order to monitor for complications and ensure the resolution of the headache. EBP through an epidural catheter. The effectiveness of EBP performed through the epidural catheter in parturients with unintended dural puncture was recently examined. In this study, the duration of the headache was shortened, but the incidence and severity were unchanged. Given this information, we recommend EBP through an epidural catheter only for patients whose epidural catheters were extremely difficult to place and are at higher risk for repeat dural puncture with EBP. Contraindications to EBP: immunosuppression, systemic infection, coagulation disorders, and patient refusal. Other treatments: intrathecal catheter. Recent advances in parturients suggest that when an unintended dural puncture occurs and the anesthetic plan included an epidural catheter, placing the catheter in the interthecal space may reduce the incidence of PDPH. Headache incidence is reduced most patients whose catheter is left in place for 24 hours after delivery. Extreme caution must be taken when an intrathecal catheter is in place. Communication to all the staff, nursing, obstetrics and anesthesia personnel about the presence of an intrathecal catheter is paramount. Clearly label the catheter as intrathecal in order to prevent administration of medications intended for intravascular or epidural administration. Care must also be taken to prevent the infection. Managing a patient with a PDPH in whom the EBP has been ineffective. In the vast majority of the patients with PDPH, 2 blood patches will result in resolution of symptoms. Indications for imaging studies and/or consultation with a neurologist include unresolved headache after 2 EBP, worsening headache severity, or changing characteristics including loss of positional nature, fever, and associated sensory or motor deficits. Now we come to the summary of PDPH and epidural blood clots. Patient characteristics. Increased risk in women age less than 40. Decreased risk with obesity. Signs and symptoms. Positional improvement with supine position. Frontal occipital. Throbbing. Associated photophobia. Double vision. Nausea, vomiting. Differential diagnosis must always be considered and patient thoroughly evaluated. Includes musculoskeletal headache, caffeine withdrawal, migraine, meningitis, subarachnoid hemorrhage, and subdural hematoma. Treatment. Conservative measures include caffeine and hydration and have limited effectiveness, EBP, most effective. Thank you. This much is for today. We have come to the end of this discussion.